Uh, Good afternoon, everybody. And it's always a challenge to talk in a pre-prandial session. A sincere thanks to the organizers for calling me over here. And more importantly, it is always a prestige for me when my teachers are in the, the chairpersons for the meeting. A big thanks to them. Today I come here as a cardiologist working in the field of transplant, and I'm trying to look at how a colleague cardiologist expects from us. So it is like, role reversal. In fact, Dr. Kamaldeep talked about, your avatar staying outside and looking at you. So I have been a practicing interventional cardiologist for the last 18-20 years. Now I get into a different avatar as a transplant cardiologist. And as a cardiologist, what my expectations from this subset is what I am going to discuss over the next 20 minutes. Before I embark on this, I always feel this is a graph you might have seen 100 times in all cardiology presentations. Everybody talks about this graph. Everybody talks about this natural history of heart failure. But the point I want everybody to realize is that every time a patient has, it's not working, every time a patient has one episode of heart failure, he recovers. We all know that. But the important point I want everybody to note is when he comes up, he never comes to the place from where he fell. He comes up to a place which is lower than from where he fell. And that is the gist of my discussion today. Every episode of acute decompensated heart failure, patients do recover, patients do go home, but they never ever come back from where they fell. So this is why this is important is when we look at this natural history, every patient is worried about that acute decompensated heart failure episode. But as a heart failure cardiologist, I personally feel every episode pushes him down, down and down. Despite the fact that he has recovered, the recovery is never back to normal. The reason why I am so obsessed about this is, this is again the same graph. So everybody assumes our challenge is in this field where transplants are there, devices are there, all those things are there. But my personal belief is the effect is here. This is where I want every clinician to pay attention. 20 years back, in the same forum like this, people have discussed about primary PCI. At that time, all of us in the audience would have been skeptical because at that time, nobody would have believed that primary PCI will revolutionize the management of acute myocardial infarction. I want the same sincerity towards acute decompensated heart failure management because the traditional management of heart failure is laid back. The same way the traditional management of acute myocardial infarction was laid back. If we incorporate the same seriousness that we afford to an acute myocardial infarction, the outcomes can be very different. So the point I am trying to stress upon is the traditional way of looking at heart failure needs a rethink because every time you go by traditional, more likely that the graph tends to go downhill and every time the patient recovers, he never recovers to normalcy. This is very interesting. I'm sorry. This is very important because when you look at heart failure, so many people in this audience might be thinking, I also have a lot of patients of heart failure. Many of them have EF of 15% and all of them are roaming around. Why this gentleman comes and talks as if everybody with EF of 30% needs a transplant? This is the reason. This is something which has emerged as a new concept in heart failure is phenotyping of heart failure. Because traditionally we assume we divide people, like for example, 20 years back we talked about systolic heart failure versus diastolic heart failure. Then we talked about right ventricular failure versus left ventricular failure. Then we had concepts like forward failure, backward failure. But we could not predict outcomes based on these numbers. In fact, for the last 10-15 years, we are obsessed with EF as a determinant of heart failure. That's why the European Society of Cardiology introduced a concept, mid-range EF. Then they came out with a concept, improved EF. patients who had heart failure with mid-range EF with improved. So many new concepts, because for the last 15 years, we are obsessed with one value called as EF. But unfortunately, EF does not predict outcomes. So what predicts outcomes? One of the tools that Kamaldeep sir mentioned is AI. That is based on these issues. Why I am stressing on this is, if you look at these issues, this is very important, because every heart failure has a different outcome depending on the phenotype. For example, an elderly female with hypertension, with atrial fibrillation, she may get admitted 20 times in your ICU. But the only thing you have to do for her is control her heart rate and she goes home. She never dies. But at the same time, the other extreme, young fellow, severe MR, LV dysfunction, he is not going to last even 3 months. He is going to die. So this is very important, because now we genuinely believe phenotyping in heart failure makes a huge impact on outcome. And that is where the changes in management come. As a heart failure cardiologist, I always get very excited when we come across what we call as reversible causes. I still remember when I was a postgraduate in medicine, the most happiest moment was treating hypoglycemia. Patient gets up and goes home. So you are so happy. The same gratitude or same sense of achievement comes to me when I face a patient with reversible cause of heart failure. This is very important, because I am not an oncologist, but recently we wrote up a paper on cardio-oncology, and believe me, there are 597 cancer drugs which affect the heart. And I can openly challenge on this forum, all my cardiology friends do not know the spelling of 99% of those drugs. The reason I am impacting this is a potentially a dangerous trend, because all the newer cancer drugs, I have nothing against oncologists, all the newer drugs which are what we call as immune directed therapy, almost all of them hit the heart very hard. So if your patient has received any immune modulation for his cancer, take it from me, he needs surveillance for heart failure, because down the line he is going to become your patient rather than the oncologist patient. And that is the reason I want this history taking to be very robust. The more important, even more than cancer, is what I call is immune-based rheumatology. Immune-based rheumatology is more dangerous, because the patient will never give you the history of taking those drugs. They would have taken 1 shot, 2 shots, then they didn't afford, they stopped it. And one fine day they land up with heart failure. And that is the bigger challenge. So if a clinician, if you are a good clinician, it is very, very important to look for immune-based rheumatology, because that is going to hit your patient hard. And if you diagnose it, you are going to stop those drugs. And that is the reason I, as a heart failure specialist, always look for this history. I always look for occult myocarditis, because these people recover extremely well. We have had patients who have got referred for transplant just 2 months into their heart failure. We tell them, please wait for 3 months. There is a great possibility, if this is a case of occult myocarditis with a history of fever 2 months prior, these guys are going to make a very good recovery. So these are things which is very, very useful. Regarding sarcoid, I believe it is the cheapest heart failure to treat. The reason is these guys improve like dramatically with steroids. Every month we come across at least one case referred for transplant, but turns out to be cardiac sarcoidosis and almost completely reversible with just steroids or immunosuppression. The other option, amyloidosis, is still an expensive option, because transthyretin amyloidosis has a treatment called tafamidis, but I am very sure anybody in this audience will find it very difficult to afford tafamidis. That's a different ball game. But last but not the least, tachycardiomyopathy. If there are any electrophysiologists in this room, they will vouch for me that every month at least one patient comes to them which has uncorrected tachycardia, and that guy eventually leads to heart failure. And if the electrophysiologist can pick up these patients, they can reversibly treat these patients. This is very important because at the end of the day, finding out a reversible cause in heart failure is always a good option. Now coming to the gist of my discussion is when I should always consider a patient for referral for heart failure, transplant, evaluation. So this is very important. The clue is that repeated admissions. That is very important. If somebody gets admitted say 4 times in a year, take it from me, he is giving you the signal that he is not going to pull on for long. That is a class 1 indication to refer a patient for a transplant. The problem is till the patient has one organ involvement, take it from me, his outcomes will be excellent. Unfortunately, we see patients when their kidneys are gone, their liver is gone, and then the family says, do everything possible. I am telling you, the moment cardiorenal sets in, cardiohepatic sets in, the death knell has already been sounded. So they never ever try to transplant in that subset. And single end organ damage is always a class 1 indication. We have a family from Maharashtra. They are all members of Legislative Assembly. All of them have DCM in their family, and they are probably, obviously they are a very rich family. All 3 brothers have received a heart simply because everyone in their family died of sudden cardiac death in the past due to inherited cardiomyopathy. So in these patients, the moment you have first symptoms, make sure that these patients are listed for transplant. Many physicians will always say that what should prompt me, what should make me think that I should involve a heart failure specialist. So this is an algorithm formed by the American Heart Association, and the concept is called I need help. Just like in our undergraduate days, we always loved this mnemonics. No, if you have mnemonics, we remember in exam. So same way they tried to form a mnemonic and tried to talk about a mnemonic which helps people to remember which patients needs referral. Among this, the top is very important, IV inotropes. Somebody is in and out of hospital needing IV inotropes. Somebody showing end organ dysfunction, creatinine is going up, bilirubin is going up. These are subset of patients who need effort. I give lot of importance to hospitalization. Repeated hospitalization is another indication where you genuinely believe. For example, P. See, P is very important. If the patient does not tolerate drugs, he is telling you some signal which you should not miss. For example, if a patient does not tolerate even 1.2 milligram of bisoprolol, that means please look for amyloidosis. Why I am giving you this important clinical thing is, these are clues that the patient is telling you there is something wrong with him that is not responding. So somebody not tolerating beta blockers, your red flag is this guy could be having amyloidosis. When not to refer, this is very important. I found it very sad that 3 years back one of our colleagues published in the newspaper that they did for a 78-year-old guy heart transplant. So newspapers loved it. I know that the patient died after a month. This is something which we should understand. Media is something which loves such sensational stories. Why nobody in the West transplants above 70? It's not that we cannot do a transplant. These people will not tolerate immunosuppression, will succumb later due to other reasons. So it is not a heroic thing to do a liver transplant or a lung transplant in a 78-year-old male. The reason is these people do not do well. For example, for years, history of cancer was considered as a contraindication to transplant. One of our former prime ministers had a renal failure, but he also had multiple myeloma in the past. So he was refused a kidney transplant because the guidelines are crystal clear. Any history of cancer is considered as contrary. Now the guidelines have changed and they say cancer-free survival of more than 5 years entitles you to be listed for transplant. The most important reason I would refuse a transplant is a non-compliant patient. I never ever want to transplant somebody who is not going to be sincere with immunosuppression, who is not going to come for follow-up, who will not come for surveillance biopsies or surveillance evaluation. I personally feel that is the absolute no-no for transplant. And I always believe if you don't have a family support, this is a big contraindication. I know nobody in India the only contraindication for transplant is absence of bank balance. But in the West, the important reasons for people to refuse a transplant are these issues. A short information about outcomes. So when you look at it, heart is the only organ which is the most immunotolerant solid organ transplant in the world. The liver people fight with us, but if you look at actual numbers, we do better than the liver guys. The reason is heart is the most immunotolerant organ as compared to any solid organ. The next is liver, next is kidney, and lung has the worst outcomes. So when I was a treating cardiologist, in patients with a borderline respiratory reserve or a borderline pulmonary pressures, I used to refer them for heart and lung because I thought that is what I am doing good for the patient. But now I have realized that I should optimize this medical management so well so that I can avoid listing them for a heart lung, because heart and lung outcomes are not that great. So I always wish to do only a heart transplant and not combine with lung, because lung is like an open organ. So it's always susceptible to infection, always there is issues with immunosuppression. I personally always prefer heart as an isolated option. Unfortunately, like Dr. VC sir mentioned about echo for a traditional cardiologist is only LV. But if you are looking as a transplant cardiologist, it is the RV which decides the outcome. If I am a transplant cardiologist looking at the echo, I am more obsessed with the RV function, because RV function is going to tell me how this patient is going to make. People with bad RV do very bad. So that is the reason it is very important that patients with RV dysfunction are not a good candidate. So this is, I'll briefly go through these things. These are things already discussed. Ischemic cardiomyopathy is a commonest reason that people get referred for transplant. Now the guidelines are very clear how to approach them. There are clear data to suggest that look for inducibility, look for evidence of ischemia, and try to revascularize these people as much as possible. If everything else fails, then only you should consider this thing. So whom should you always consider? So for example, our class 1 indication would be ischemic cardiomyopathy with no scope of revascularization, patients with idiopathic dilated cardiomyopathy, patients with inherited cardiomyopathy, burnt out hypertrophic cardiomyopathy, complex inoperable congenital heart disease, and Eisenmenger's. Whom should we consider? MCS, that is mechanical circulate. All those patients whom we sincerely believe that we can reverse should always be considered for MCS. So with an ECMO, with an Impella, we can reverse for most of the patients. These are the subset of patients, select subset of patients whom I believe we should not offer transplants. We should offer LVADs. The reason is they do not do well with transplants. O positive, although it's a common blood group, somehow we find the donors are the least in O positive. So it's a paradoxical thing, but it's a very true thing. So O positive is another situation. Patients who have high immunogenicity, like mother of many children, multiple transfusions, these are issues where we consider that LVAD is a better option. Before I end, I think I have 2 more minutes. This is the status in my state from where I come now. We have done more than 80% of transplants that have happened in the country. The reason is we have a culture of donation, and that has made things dramatically different. For example, the average waiting time in US is 2 to 3 years. The average waiting time in Tamil Nadu is less than 6 weeks. Average waiting time in Singapore is 8 years. This is something sadistically, because we have the world's largest accident rates also. We have the world's largest non-helmet wearing people. Those are sadistic truths, but this is the data. The reason is we have completely made it as like Kamaldeep said, Internet of Things. Everything is automated. So the chief minister of our neighboring state could not get listed and he died waiting. Similarly, all people with all international patients are absolutely now not possible. So only Indian patients can hit the list and nobody can bypass the list. The another state government initiative is to give state funeral to donors. That has revolutionized the acceptance. I think we'll skip. So a word about ECMO. ECMO is never treatment, it's only a bridge. It's bridge to recovery, bridge to decision, bridge to transplant, bridge to device, but never destination. LVAD is for patients who cannot get a heart. In the West, LVAD has picked up like anything because they don't get a heart. But still, I'm not happy with the present LVAD. Two reasons: it's too expensive, and the wires come out and they have to wear a battery. That's why I have not. So this, they have done what we have with our phones and our devices, what we call as wireless charging. So I think, I know this is not FDA approved, this is still in a very experimental phase, but this will be the future because world is betting heavily on this. The reason is we are not getting hearts in the West. West hearts are very scarce. In the entire US, the transplant numbers are not increasing except for a small increase that has happened because of cocaine abuse in the West. The second reason people are getting more hearts is they have something called as a donation after circulatory death. That is a concept which has come. We'll skip this. But before I conclude, as a treatment, we all are very enthusiastic to treat. But as a clinician, we should always remember when not to treat. So palliation is something I genuinely believe every clinician should consider when you reach a state where something too much is too much. So this is something I feel is a genuine concern. Just because we have treatment on offer, just like that newspaper article I said, should not be done. We should know, we should never make anybody live against their wishes just because his son based in US is ready to spend 1 billion for the patient. Thanks a lot for hearing in the preprandial state. Thank you.